Well, I just wanted to briefly introduce David Harlow, who has been gracious enough to do this affiliate call for us today. He is the founder of the Harlow Group. He is a healthcare attorney and consultant. He is considered a thought leader in both health law, strategy, and policy. He's got over 25 years in both public and private sector experience, so he's got a lot of knowledge about health policy relative to the Affordable Care Act and how it will affect each of your individual affiliates. And after today, if you'd like to continue to follow David, he has his own blog, Health Blog, and I'm sure he can send some information about that to the rest of the affiliates. So, David, welcome, and thank you very much.
Thank you very much. It's a pleasure to be with you today. Well, you've heard the introduction, and I'll finish up the introduction by saying, hi, I'm David Harlow, and I'm from the future. I'm from the future in that I am also based in Massachusetts, as is Joslin, and our home state is a few years ahead of the rest of the country on the path to implementing health reform. As you know, the Affordable Care Act is based in part on the Massachusetts health reform law, and Massachusetts, frankly, has been tinkering with electronic health records and universal health coverage for decades. Today we'll be talking about some challenges and opportunities that lie before healthcare provider organizations in every state of the union. All of us, all provider organizations, large and small, are geared up to provide healthcare services to patients. They rely on a steady stream of patients and adequate reimbursement for services rendered. Health reform is really making it harder for providers to succeed because it layers new thinking about care delivery and payment over existing structures and operations in ways that, as you know, sometimes to be contradictions in terms. You all need to get smart about ACOs, accountable care organizations, and the other shared savings programs, bundled payment programs, care coordination programs that are in the health reform law, and other federal, state, and commercial payer innovations. And you need to begin or continue making the structural and operational changes necessary in order to ensure continued financial success to support your mission in the future. You need to partner with the government, with commercial payers, with other providers, with Joslin for the affiliate network. You need to be a disruptive innovator. If you stand still, or if you sit still, like Ramses II over here, you could get swallowed up by the sands of the desert. The goal for all of us in healthcare these days is to be better integrated with other parts of the system so that over time we are able to do more with less. That really has to be the mantra. Everyone from the White House to the CMS, Center for Medicare and Medicaid Innovation, to the C-suite at Aetna, to everyone on this call today, knows that we will have to do more with less. The key to future success will be managing patient care and its costs over the long term, managing episodes of care that extend far beyond an inpatient admission to encompass pre-admission and post-discharge services, managing a chronic condition such as diabetes with a multidisciplinary approach, using medicine, nursing, and even social media and game theory to motivate patient behavior modification. We need to move from reimbursement-based medicine to evidence-based medicine, and the information systems supporting the practice of medicine and making all this possible have become more and more important. And look, we're spending $23 billion in federal funds on meaningful use incentives for the implementation of electronic health record systems. And Aetna, which I mentioned before, has even stopped calling itself a health insurance company. It's in the health information business now. So let's start with articulating the goals of the Accountable Care Organization program and related programs under the Affordable Care Act. John Berwick, before, during, and after his, shall we say, abbreviated stint as administrator of the Centers for Medicare and Medicaid Services, has been talking about the triple aim of better care for individuals, better health for populations, and reducing per capita costs of care. So this is now the official policy of the Centers for Medicare and Medicaid Services. The Center for Medicare and Medicaid Innovation within CMS has been handed a pile of cash under the Affordable Care Act, $10 billion to be specific, that's billion with a B, to spend over the course of 10 years on figuring out how to translate this vision into reality, going way beyond the accountable care organization model written into the law. They're getting creative with a bunch of interesting initiatives underway and with more to come. The triple aim is a mantra we should all internalize because it is a goal that we all share for all populations, not just Medicare and Medicaid beneficiaries. So, the Accountable Care Organization. I want to ask, do you know the definition of a camel? The definition of a camel is a horse designed by a committee. And that is what the Accountable Care Organization legislation and initial round of regulations look like. Definitely camel material. It's a compromise that CMS and other agencies have been working to implement. After some redesign, I would say the final regs that came out looked a little bit more like a horse, and many providers and provider associations went on the record saying that the final version looked a lot better to them. Initially, folks seemed to think that it wasn't worth the trouble and expense of getting into the ACO program, but then there's been a lot of enthusiasm and focus on ACOs as one of the centerpieces of the health reform legislation. We'll examine whether this is warranted. We're now up to about 250 Medicare ACOs and about the same number of commercial ACOs nationwide, maybe a little bit more. The numbers are a few months out of date, and growth seems to be slowing. So let's talk for a moment about what exactly is an ACO. Under the law and the regs, an ACO is a legal entity that makes a 3-year commitment to CMS and that engages in one or two-way risk sharing, meaning exposure to upside potential, upside risk, which is a good thing, right? And also exposure to downside risk. If you agree to have exposure to the downside risk, then CMS will agree to share a greater proportion of the upside potential back with you. A full provider network is needed either by membership in the ACO or by contract, and providers may belong to only one ACO. There are performance measures. There are 33 performance measures that need to be tracked as part of participating in an ACO, and some of them focus on individual patient health, and some of them are deliberately focused on population health. Because as we'll see, what CMS is trying to do is leverage its purchasing power to really force the provider community, or to nudge the provider community, into thinking more broadly about population health. Some of the key requirements in the ACO legislation are patient engagement and patient-centeredness. And I have to say that inclusion of these terms in a statute by Congress is really a watershed moment. They're more fully defined in the regulations, but a key feature of the regulatory flexibility is exemplified here. The regulations are really not prescriptive to the new day for the federal government. They say, show us how you are patient-centered across a number of domains, but without really saying exactly how to go about being patient-centered.
There are a couple of other pieces of regulation in here that relate to fraud and abuse, the IRS, and antitrust regulations as well, making exceptions to those rules in order to make the ACO rules work.
The focus then is on the question of how does somebody get qualified to be an ACO? What does that mean over the long run? We do have to ask, are the ACOs a mainstream force to be considered, or is this really just a drop in the bucket? I mean, on the one hand, we say 250 Medicare ACOs. That sounds like a good start, But as you know, there are 6,000 hospitals in the U.S. And all in all, Health and Human Services estimates just point to $500 million to $1 billion savings to Medicare over 4 years. The Congressional Budget Office was a little bit more optimistic at the outset here, expecting $5 billion in savings over 8 years. But look, this is a drop in the bucket. We're talking about 2 million or so Medicare beneficiaries out of nearly 50 million Medicare beneficiaries overall. And we're talking about Medicare, which is a $500 billion a year line item. So all in all, the early years of the ACO have not been that promising and may not even hit these projected savings, even though the ACOs were really the darlings of the health wonks who dreamed this stuff up. And these ACO initiatives seem to be generating a lot more interest than perhaps they should, for a couple of reasons, I think. They really form the conceptual building blocks for a new approach to achieving the triple aim: better care, better health, and lower costs. But let's get back to the camel. So I titled this talk, "The Camel's Nose is in the Tent," for a reason. The image evokes the beginning of a significant disruption, and that's exactly what we have on our hands with the Affordable Care Act's provisions about ACOs and related initiatives, as well as the market-based changes that are happening around us and around the implementation of these legislative changes, including, for example, the commercial ACOs, which really preceded the Medicare ACOs in the market. It's really a sea change in the way the healthcare industry in this country is conceptualized. Both delivery and payment systems are going to be radically changed, away from fee-for-service in the direction of budgeted caps with quality kickers, with an increasing awareness that the patient is at the center, not just as the object of all the healthcare being delivered, but as a partner with healthcare providers in designing plans of care that can work. Now, this shift has been underway for several years, and it's been happening in commercial markets, as I said, even before the Medicare and Medicaid markets. And this is one of the sorts of things that you need to prepare yourselves for if you're not already doing it. This is really the latest form of pay-for-performance, value-based payment. Let's go back to what might be the beginning of value-based payment in healthcare. Traditional Chinese medicine, so the story goes, a village acupuncturist is paid a monthly fee by each person under his or her care, so long as the patient is healthy. If an individual falls ill, then the practitioner is not paid. So I like the philosophy underpinning this system. We have built a system of sick care, not health care, but the disruptive forces in the Affordable Care Act have the potential power to change our system to a system of health care by changing the focus, changing the incentives, changing behaviors of both providers and patients. As I said, population health management is what it's all about. CMS is leveraging its authority by saying in the regs that an ACO must have at least 5,000 patients, which is kind of a low number if you think about it. But the effect of the ACO's practices are expected to be magnified because patients are attributed to the ACO retrospectively, based on the plurality of primary care encounters. It's really a retrospective look. So that means that an ACO must treat each patient who comes in the door as someone for whose care it will be on the hook financially, because we won't know until later whether that person's a member of the ACO or not. Well, kind of a silly rule in the abstract, but there you have it. This is, again, part of the Camel part of the ACO. It's congressional compromises and so forth. And Congress and the agencies didn't want to limit patient choice here. So a patient is not going to be restricted in the choice of providers, even if that means that the patient goes outside your network for care which hits your budget, assuming the patient is ultimately assigned to an ACO. So it's problematic. It's a problematic setup. And in the final regs, CMS even went so far as to say that it was not going to protect providers from unmanageable patients, saying that it's up to providers to figure out how to manage the quote-unquote unmanageable patients. So how is all this supposed to work? How is care supposed to be managed here, and how are ACOs supposed to make money? Well, ACOs get to share in the cost savings they experience versus what it would have cost to care for their populations on traditional Medicare. This is based on the PGP demo, which preceded the ACA and which formed the basis for ACOs. This is a graphical representation of data shared by CMS when these demo participants re-upped for an additional term. Now you can see here, if you can't make all the details, that with 10 participants, there was only one that was doing really well. It was a Marshfield clinic. Now, you have to think that the rest of these folks planned pretty carefully, and they're no slouches, Billings Clinic, Dartmouth, etc., but they didn't make much money from participating in this demo. Interesting question. Not 100% clear what the answer to this question is. Now, we all know that 5% of the population, the chronically ill, medically complex cases, account for 50% of the healthcare spend. Top 1% account for 20% of the spend. Focusing on controlling costs will yield some good results here. And perhaps that's in fact what the Marshfield Clinic did, designing programs to manage chronically ill patients' care through structures like medical homes and with other supports. Though as I say, the other folks on this list are no slouches, and clearly they would have tried to implement similar things, yet they did not succeed. Overall, the risk-reward ratio for ACO seems skewed. There's a tremendous investment that's required in order to make this work, and there's little guarantee of a return on that investment unless you have, I guess, the secret milk recipe from the Marshfield Clinic, which serves rural Wisconsin. So JAMA, in the earlier days of the ACO initiative, published a piece that said that the problem here was an overestimation of organizational capabilities, a failure to balance interests and engage stakeholders, a failure to recognize interdependencies, and that folks were eager to jump into the pool here but weren't really ready to do this successfully. So, I mean, success really requires a couple of things, and two of the things I'd focus on are these. In order for a shift in reimbursement strategy to result in improvement in health outcomes, many pieces of the puzzle need to be put together in advance. And this hasn't been done by some of the early Medicare ACOs. Others, frankly, may have been doing this well for years and thus have already wrung the savings out of their systems. So to me, that explains possibly why places like Dartmouth didn't do so well in the PGP. They've already figured out how to be an effective, well-oiled machine, and the financial incentive as part of the PGP demo didn't drive them to do that much better than they were already doing. The keys to success really involve understanding the human-level changes that will drive system-level financial results. They'll differ from system to system, but should share some general characteristics. So we're talking about the chronically ill, patient-centeredness, because the patient's not going to work hard at home to achieve goals that were printed out for her, but not identified by her as her own. We're also looking at abandonment of fee-for-service payment methodologies, having the health delivery system assume some of the risk of the quality of the care it delivers. And by that, think about readmission, reimbursement policies. We're not going to pay you for an unnecessary readmission, but we don't want to thrust onto the providers insurance risk. Think identical diagnoses for patients with widely varying severity of disease or complications or comorbidities being paid the same. We don't do that. There are acuity adjustments to fee-for-service reimbursement there. So we also need to talk about the ways in which the pieces of the delivery system fit together. The ACO model requires a high degree of structural integration, but that alone does not guarantee clinical integration. The clinical integration that would be facilitated by health IT systems as well as personal relationships that need to be built are the things that will help assure success across care settings and across providers. So despite all these difficulties, 3 or 4 years back, over 60% of healthcare provider executives said they intend to form an ACO even before the rules were out. So this says to me, with the benefit of some hindsight here, this says to me this is a fantastic cry for help. There's a need for change. There was a desire to do something different. The ACO appeared on the scene, and people said, yes, that's what we need to do. But with a little experience under our belts, early adopters have been stepping out of the pioneer ACO contracts because they're not realizing that savings, shared savings. Leading healthcare organizations are seeing virtually no benefit from participation. And we'll get back to this in a moment. But this is all to say that the key to success here is a culture of collaboration, where we're seeking to manage care and cost across an episode of illness or across the lifetime of care for a chronically ill person, not just in a siloed acute care or post-acute care setting, not just the professional fees, not just the facility fees. Everyone needs to come together and adopt models of care and reimbursement that go beyond the ACO model, such as the patient-centered medical home, which some of you have already been implementing, a budgeted payment approach, other payment ideas as well. Overall, we really need to move, as I said, from a system of reimbursement-based medicine to evidence-based medicine, remembering that patients are a key part of the equation, and we need to align incentives so that clinicians and patients are empowered to make better decisions together. Let's assume that an ACO is not in your immediate future, Medicare ACO, but you do need to prepare now for value-based payment contracts if you're not already dealing with them. So unlike on the Medicare side, the commercial plans are non-standardized. The Medicare ACOs are pretty standard. There are other CMS initiatives that are open. And remember, the Center for Medicare and Medicaid Innovation exists to run experiments. Under commercial insurance, there are many programs that are being referred to as ACOs, and they do a variety of different things. And in my neck of the woods in Massachusetts, the Blue Cross Blue Shield of Massachusetts Alternative Quality Contract is a commercial ACO arrangement. And I have to say that the commercial ACOs are not delivering improvements above and beyond what the highly evolved provider networks are already capable of delivering. We've seen that in Massachusetts with some of the more evolved networks participating in the AQC and not necessarily seeing a terrific change, though less highly evolved groups saw a benefit from participating. So, your mileage may vary, as they say. Now, let's think for a moment about the ACO system as sort of a unitary approach under Medicare. And I wanted to highlight this idea put forward by Jeff Goldsmith in a piece in Health Affairs a while back in reaction to the federal ACO regs. He basically recommends risk-adjusted capitation payments for primary care, fee-for-service payments for emergency care and diagnostic visits, and bundled severity adjustment payments for episodes of specialty care. So primary care could be provided through a patient-centered medical home model, which would likely have a collateral effect of reducing the total volume of emergency care and the diagnostic physician visits. Specialty care would be provided through specialty care marks, ideally more than one per specialty per market in order to maintain a little healthy competition. And the idea here is that one of these payment systems ought to be just right for each provider type. Now, if you own a particular geographic market or the population of a large self-insured employer, you may be in a position to experiment with these ideas and structure payment for services along these lines. If the employer is willing, the insurance company administering its plan should be able to accommodate the employer, and you can implement some of these ideas that are sort of drawn from the health reform law but implemented in a more freewheeling way in the commercial sector as well. Now, the Medicare Shared Savings Plan, which we refer to as the ACO, is really just one arrow in the quiver. So there's a whole raft of initiatives that were rolled out as part of the Affordable Care Act, most of these coming through the Innovation Center. And some of these have been implemented, others will be implemented over time. And again, if you have an idea that they're not already working on, those Centers for Medicare and Medicaid Innovation want to hear from you. They'll take a look and they'll consider adding it to the list. They're in the business of throwing stuff against the wall and seeing what sticks, what works. So they're open to ideas, which is refreshing. That hasn't always been the way of the federal government. So let's look at a couple of examples that have been started to have been rolled out, and we don't have results necessarily yet. Bundled payments for care improvement contract is just one of many that we see coming out of CMS. This is one that some provider groups decided to pursue to get their feet wet without committing whole hog to the ACO model. CMS basically called for bundled bids on different sets of services, say pre-admission services or inpatient services or post-discharge services for certain DRGs. Some participants in this initiative have picked a number of diabetes DRGs and are working on post-acute hospital discharge diabetes care in this demo. So they're bundling rehab, home care, and other post-acute services into a single episode where there will be a single bundled payment. And then other DRGs are the subject of this as well. It's not just diabetes, but diabetes is one of the areas that's being pursued under this demo. Another example is called care coordination, and this is basically a patient-centered medical home kind of setup where primary care practices in half a dozen or so states are receiving a monthly kicker from Medicare for fee-for-service enrollees in order to coordinate care, to function as a medical home. And the goal is to encourage private payers in those markets to participate as well. And in fact, that's required in order to participate in the program. So again, Medicare is leveraging its dollars by bringing in some dollars from the private insurance market as well. Medical practices that participate in the program and meet quality measures will be eligible to keep the share of savings that they generate. So the idea here, again, is to provide primary care doctors with funding and flexibility to manage chronically ill patients and coordinate care. Now, to me, you combine these two, and that's sort of the holy grail, a combination of bundled payment and care coordination. So the ACOs, which I went into some detail at the outset here on ACOs because they've been such a keystone element of the Affordable Care Act, ACOs have really been unable to demonstrate value. Initial numbers for the first approximately 120 Medicare ACOs show that half met or exceeded their targets and half didn't. And of the ones that did, only a tiny fraction actually got to share in the savings to the Medicare program. Some folks are saying it's still early, we need to tweak the model, etc. But to me, the bottom line, even after the significant expenditures associated with an ACO startup, which include IT infrastructure investments in the millions, physician practice acquisitions, hospital mergers, care management plan development, etc., ACOs in the Medicare arena really seem to not be working. So I propose that we leave this behind and think about an approach to care financing and delivery that would actually improve outcomes and lower costs, the holy grail of healthcare. And that's this combination of bundled payment and care coordination. We need to tear down the wall between payment reform and delivery reform and do it more holistically. So we have payment system reform, these shared savings ideas, bundled payments, global payments. We can't call this capitation anymore. I slipped in the word capitation earlier, but that word seems to be verboten. And we're also talking about delivery system reform, breaking down silos, creating, whether it's ACOs, which I think is not the way to go, or medical homes, or other variants of such provider organizations. These changes trigger a whole host of legal issues because the rules have been written in order to accommodate fee-for-service medicine. And once you move away from fee-for-service medicine, you create all of these problems in terms of antitrust and Stark and anti-kickback and tax exemption issues and fee splitting and state insurance law issues like providers bearing risk. ERISA is sort of an additional layer of fiduciary responsibilities that are added in here. Now, payers such as the United Health Group and others are saying publicly that they're shooting for transitioning 50 to 75% or more of their members to performance-based payment contracts in the very near term. So this is attractive and of interest not only to Medicare but also to the large commercial payers as well. 60% of health plans nationally expect more than half of their volume to be in value-based payment plans within 5 years. And I want to pause here and say that what's interesting about the large payers is that they're not as monolithic as they seem, and there's opportunity for more individualized discussions here. For example, United Health Group insures only about 40% of the covered lives it manages. The balance are self-insured, and employers can and do initiate their own programs. Let's talk about things that can be done here. What I'll call this is primary care on steroids. It's a model that seems to be working very well and achieving some of the results that are eluding the ACOs. I blogged about this a while back in a post called Primary Care is the New Black. Now, self-insured employer groups and the insurance companies and healthcare delivery systems that work with them are at the leading edge of innovations that bring together bundled payments and care coordination into a winning combination. They're improving care, improving outcomes, and saving money. They're achieving the triple aim. We spend 50% of our healthcare dollars on 5% of the population. So what some folks have done, they've decided we need to double down on primary care, investing in health coaches as well as primary care providers. And if you do it right, you can cut emergency visits in half, cut hospital admissions almost by half, and end up saving 50 to 20% of the total healthcare spend. And this is an example drawn from the experience of Iora Health, which is managing workplace health clinics and worker health partnerships with, as I said, employers and payers. So I would invite you to check out these interviews. These are live links to interviews with 5 examples of leaders of organizations. They all spoke at Joslin's Diabetes Innovation Conference last year. You can listen to the interviews. You can read them, your choice. At the end of today's call, I'll give you the link to this presentation online that has live links to these interviews. I think it's sort of worth checking it out because there's really room for a lot of experimentation, a lot of innovation here. The key takeaway, though, really is that you have to put the patient at the center, and that's what these organizations did. They recognize that you need to engage the patient in defining and implementing solutions for his or her own healthcare needs. We can add meaning to this general observation from our own experiences, but we can also learn some lessons from the 5 groups just identified. I think the core of this here is that you need to meet the patient where she is. So there are many dimensions to patient-centeredness. Let's start with asking the patient what's important. You have to tailor care to the patient. One of these successful centers said, you have to ask the patient, what bothers you the most? If things go well in our work together, what do things look like a year from now? What are your goals? As I said before, patients need to be subjects, not objects. You need to tailor care to patients at different stages of a chronic disease. Obviously, a 15-minute office visit for someone recently diagnosed with diabetes is vastly different from a visit for someone diagnosed years ago and managing well. You need to communicate in a way that really reaches the patient. Here's one example from an inner-city provider. They pay stipends to health ambassadors who live in the community and spread the message devised by the health center and patient groups, leading to increased attendance at screenings, greater receptivity to other aspects of care, improved self-care, and others. Experimentation is key. You need to find something that will work in your particular setting with your particular population, but we have a pretty good idea of what works. One question that often comes up is whether these experiments ought to include financial incentives. When I did these interviews, one subject responded to my question about incentives by saying this: if I have to pay you money to not stick a pin in your eye, we have a problem. There's a difference maybe between that sort of incentive and incentives that deal more broadly with the situation. So one solution gets us to a place where information presented in an engaging manner will reach the target audience and promote behavior change without direct financial incentives. For example, a program to reduce consumption of processed meats engaged 2/3 of the patient population as a result of the educational efforts in this one group. Grocery store discount cards were offered to program participants, making compliance with changes in diet easier to implement. But the key was the information presented and the manner in which it was presented. And that's what I want you to take away from today's call, is that we're not only talking about delivery of healthcare and healthcare delivery, healthcare financing. We're talking about a more holistic approach to a patient, which I know is already part of the way you care for patients, but it ties in very neatly to the changes in healthcare delivery and healthcare financing that we're talking about in the shadow of the Affordable Care Act. And in fact, physicians are central to the development of a quote-unquote accountable care organization. And here I'm using it in the lowercase, so not necessarily a Medicare model, but sort of an open market models. And there are a million variations on the theme here, including those that might use the bundled payment and medical home ideas that we've been talking about. You know, the most expensive medical instrument is still the physician's pen, or I guess a virtual pen these days. And with appropriate case management in the broadest sense possible, we can achieve the triple aim that we keep returning to: better care, better health, lower costs. And job one, if you're not already doing this, is getting a handle on your costs. You need to understand them. You need to understand what goes into them. You need to explore whether there are any immediately apparent savings that may be pursued without sacrificing quality. You need to explore opportunities for benchmarking, for best practices. If you're serious about this, start to get a handle on your key collaborators' costs. You may be surprised at the cost ramifications of decisions that you make that never hit your own bottom line, or decisions that your collaborators are making that hit your bottom line but not their own. The real opportunity here is to be the go-to cost-effective provider. Now, this is not just about unit pricing, okay? It's about how many revisions you have if you're a surgeon, how many readmissions you have if you're a hospital, how many avoided hospital days if you're managing a chronically ill patient. We need cost-effective, good quality care and good quality data to back it up in order to succeed in terms of contracting for the delivery of care, contracting for appropriate payments, contracting for appropriate recognition of the quality of care provided and the savings achieved for the system. As I said earlier, we're looking at an era of straitened circumstances. We have to do more with less. So the government is running a series of experiments to figure out how to do this best, and the private sector is as well. So thus far, based on the evidence that we have, I'd have to say that self-insured employers and their partners are doing a better job than the government in figuring this out. But the bottom line is that we can adopt and adapt some of the concepts included in or enabled by the ACA, the Affordable Care Act, and use those as levers to change behaviors of patients, behaviors of payers, behaviors of providers in order to achieve the goals that we need to achieve. So I hope I've provided enough of a background today to jumpstart some conversations internally in your shops about changes in payment and delivery structures in order to meet the challenges that are ahead. As some of you know, this monumental temple at Abu Simbel in Egypt has been saved from the sands of the desert and from the rising waters of Lake Nasser behind the Aswan Dam. The whole structure was actually disassembled and moved to a new location. I challenge each of you to be as open to change in the name of self-improvement and self-preservation. The rules are changing, and now's the time to seize the initiative and establish your organization as an integral part of a high-performing healthcare system by learning to do more with less, by using tools and techniques for managing population health and for improving quality. Thank you very much.